very glad to be invited to speak here today. My talk is Accurate Diagnosis is the Key to Prevention. I will be representing my group, which is me and Dr. Kelvin Wong from the Child Center. I have nothing to disclose. So 2 years ago, we were starting a journey for how do we do better triage using AI. So that's when me, Dr. Wong, and Dr. Volpe sit together and doing brainstorming. And luckily, we got something back then. This was the first instance that we can use AI to look at patient's face while we were recording a 1-minute video when the patient was describing a picture. So that was in the news back then, and we had about 80 patients back then. Now we are more than 260 patients now. So this is the entire ER pathway that we think that we can help using artificial intelligence, or people sometimes don't like artificial intelligence. Now we call it augmented intelligence, which is to augment the ability of the human users. So we have the entire stroke pathway from stroke triage to imaging to neurological evaluation, all the way down the road. So our vision is AI can assist in every part on the way and be able to do a little bit better than normal. So regarding stroke triage, because the error is going to propagate all the way to the end, if we miss it in the stroke triage, basically we'll miss the stroke. And eventually when the patient becomes very sick, of course, we'll know. But that's something that we would like to do a little bit better. And the difference between human and artificial intelligence is that you can see that for human, we have different kind of user or human specialists along the way, whereas for AI, they can consider everything together at the end. So that potentially will be a groundbreaking way to improve human intervention in acute stroke diagnosis. So this is our current way of doing AI stroke triage. This is actually the second generation already. The one in 2 years ago already patent pending. This is the one being considered for publication. We call it deep stroke. We give a very nice name now. It may look very complicated, but in essence, we are using AI to look at the microfacial motion of a stroke patient. We all know that in severe stroke, the patient's face will look a little bit droopy. But in our population, if we go back to one slide, that one pretty much showed that we are mainly interested in patients who have mild to moderate stroke. So they're very subtle facial motion. Very hard for human user to pick it up, but could be very good for AI to pick it up. So this is what we have. We have 2-stream video and audio. We break down the video and look at minor facial motion along the way, whereas in the audio we pick up subtle trace of the patient, either in the pace or in the rhythm, and then combine together and eventually make a diagnosis for every patient. This is very new data. This is about 150 patients. That's in the paper being considered right now. Currently, we have over 260 patients. As you can see that in the blue line is our current AI standard right now, whereas the dots right there in the middle, that line along the 45-degree line, is where the ER final diagnosis is. The higher the curve is, the better. And you can definitely tell we are a little bit better than the ER physician right now. So if we do a deep dive with this model, we can take a breakdown of how it performed regarding different age group, gender, ethnicity, and race. And almost in all of those instances, AI performed better than the ER physician, except in the more than 65 age group and the African American group. That AI is still not performing as good. We think that there's a good reason for it, especially for African American group, because the AI was primarily trained on data that is dominated by like Caucasian Caucasian people's face, So it's better in picking up traits from Caucasian, whereas African American was less represented in that data set. So right now, there's a push for everyone to balance the data set and make sure that African American and even other racial group are represented. So we hope that in the year to come, then we'll be able to improve that too. So the other part that we are very interested in is the imaging diagnosis. So acute stroke primarily is using non-con CT for diagnosis, and whenever there's a suspicion of stroke, they will also do CT angiography. So in this audience, I guess I don't have to talk about too much about it. So when we look at the radiology report, most of the time they just use it to rule out hemorrhage, whereas it will be best that we can actually use it to identify a stroke. So unfortunately for non-con CT, it's very noisy even though we're at the maximum radiation dose already. So what we try to do is, can AI see better than the human experts? So what we derive a strategy is we try to reduce the image noise from the non-con CT such that we can enhance the contrast of the stroke lesions. So on the first column is the original CT, the second column is the state-of-the-art AI method that we compare to, and the third column is ours. You can clearly see that the data on the third column is way better than the original one and the state-of-the-art. And most users, when they see our data, they will think that it looks like MRI, and it really does. There is a reason for it because we asked the AI to learn from the original image to something that has been averaged over time within 5 days of the same patient. So we essentially reduce the noise such that it's very similar to MRI. So our method has been validated in over 300 patients or 380 studies in a couple of years' time after the model was trained, and it's also patent pending. So here are a couple of cases where the stroke was missed. Those were missed was marked with asterisk on the top left, so that we show that our method actually improved visualization of stroke, and we got a constant contrast increase of about 2-fold at least. This is the second patient, and that's the third patient. So this one even have a couple of them because the stroke was in the very difficult area where the CT usually have a lot of image noise. But you can definitely tell that it looks a lot more easy to see. And of course the last one, the DWI, is the gold standard. So after we develop a model, we think about AI deployment, how we're going to deploy it. We cannot just attach it to any scanner because it's using AI, it uses a lot of computing effort. So our strategy is to include it in a small, tiny device that has a GPU embedded. And then this GPU is going to do all the heavy lifting so that you can just plug and play into any CT workstation. It will do it for you. So after all that, how do we improve the stroke diagnosis, right? We know that we can reduce the image noise, but if we compare to the actual gold standard, which is diffusion MRI, we see that the biggest difference now, even though the image quality is very good, what we lack is the contrast of the lesion, and that's something we are working on right now. We already did something that we're going to disclose it next year whenever it's ready. But we can actually translate the gain in the noise, reduction in noise, to increase in image contrast of the lesion. Hopefully next year we'll be able to show some concrete result. So to conclude, we show that accurate stroke diagnosis are possible with AI tools throughout the clinical workflow. And although I don't have a chance to show that, these AI tools can be combined together to make a better decision, which can feed back to the neurologist. And ultimately, these tools can be combined and implemented either in the cloud, on premises, or on the edge. Finally, I would like to thank the collaborating team, which is Dr. Volpe, Dr. Wong, and the Stroke AI team, and of course the funding support. Thank you very much.
Thank you very much, Dr. Wong. This is very interesting ways of approaching clinical diagnostics early on, and I can't wait for this kind of stuff to be in practice and every day. It would make a lot of contributions to how we treat accurately and screen patients for the treatment needed, especially with stroke being such time-sensitive diagnosis. So there's artificial intelligence, augmented intelligence seems like a new frontier for us. What makes it different than other methodologies that are out there to including clinical decision making to improve stroke detection?
So the major difference with AI method versus all the older method is that the older method tend to work in one hospital setting and not work on the others, whereas AI method is able to generalize a lot better from site to site. As long as you make your data very similar from site to site, they perform really well. So that's the major difference. And it's really ready from prime time. You can see that this kind of method is being used across industry. So it really shows the promise.
Great, thank you very much.